So I'll briefly go through the approach to the trauma. First, a brief touch on epidemiology, and I managed to get the statistic from USA. 150,000 deaths per year, and trauma-related expense is actually $400 billion. Now, coming to the concepts of ATLS, stands for Acute Trauma and Life Support. We always go for the ABCDE. That will never change for another 200 years. It didn't change for the last 100 years, so I don't think it will change again. Now, there's no need for a history taking when we see acute trauma. So this is the trauma team. By the way, that wasn't me anyway. Now, coming to the primary survey, we always talk about the first hour is called the golden hour. If you miss that opportunity, then the patient's outcome will be detrimental. So when we start with the ABCDE, usually the airway, breathing, circulation, disability, and exposure, then we go to the airway. How do we evaluate the airway? If the patient can talk to us, that means the patient has got a patent airway. And if the patient is telling me I had this accident, then you can be assured this patient's airway is pretty much okay. Then you can move on to the next aspect of the trauma, which is B. But all the patients coming with the airway or trauma, we need to think they have a spinal injury until proven otherwise. So they should be in spine protection. Now, coming to the airway interventions, they always get supplemental oxygen suction to facilitate the airway, chin thrust. And also, if the patient's GCS is below 8, they will need a definitive airway, which is endotracheal tube intubation, basically intubation. Now, this is a patient with a trauma. Trying to get an airway through his mouth or nose, it's not possible. The only way to get an airway for this patient is to lift all this up and get a surgical airway. And one knife is enough. Within 30 seconds, you can get a surgical airway for this patient. Now, the next step, once you've done the airway, we come to the breathing. And a patent airway doesn't mean patient can breathe normally. It doesn't mean that. So you must always examine the patient's chest movements especially. And we always do a chest x-ray. We can see the x-ray where there's any evidence of any tension pneumothorax or flailed chest. Flailed chest is a clinical judgment. You could see the right side during inspiration is being sucked in, so it is actually a flailed segment. Now, subcutaneous emphysema tells us a severe trauma to the lungs, especially contusion. Patient can deteriorate later that day especially. Now, interventions of breathing, again, we can go through simply all the oxygen, and the chest x-ray or the clinical judgment will tell us whether the patient has got a tension pneumothorax. Patient initially will need a needle decompression. It's a second intercostal space, mid-clavicular line. Stick a needle, you hear the zzz sound, then yes, you are in the right spot. Now, sometimes the junior registrar may show the x-ray the other way around. It has happened to me once. I stuck a needle on the opposite side. That patient will invariably get a chest tube as well. Now, always check the side. Now, coming to the chest tube insertion, we always ask in the exam, people say mid-clavicular line, fourth or fifth intercostal space, which is slightly wrong, actually. Mid-axillary line is where the long thoracic nerve is running, so we actually go slightly anterior to that, which is 1 centimeter anterior to the mid-clavicular line, fourth or fifth intercostal space. Now, this is a tension pneumothorax, we talked about it, and this is another, a widened pneumomediastinum, is actually a widened mediastinum, which is showing a evidence of any thoracic aortic aneurysm, a rupture. These patients can again deteriorate pretty quickly as well. Now, so we have finished airway breathing, coming to the circulation. The rapid assessment of circulation is very important. We can, again, patient's level of consciousness will give us an idea whether this patient is in grade 1 shock, grade 2, 3, or 4. Now, getting an access, the common exam question we ask all the time is, we are unable to get a 2 large bore cannulas. Are you happy to have 6 small ones? The answer is no. We know the flow and directly proportional to the radius of the caliber. So we will need 2 at least large bore cannula there. Now, this I'll briefly go through that. Again, we look for the GCS. I talked about it previously. Patient will need intubation if the GCS is under 8. And some of the patients, if you're suspecting an increased intracranial pressure, we can actually do the intracranial pressure monitoring device under local anesthetic. A spinal cord injury, if you suspect that, is actually the statistics showing if you give dexamethasone within 8 hours, there is some benefit, but it's not clearly understood this part of the surgery. Complete exposure, you can see sometimes there's one small stab injury to the groin and patient is pouring blood. You are concentrating on the head and neck where the patient is losing blood and pressure. Always inspect the back. Log rolling, spine protection, you may see a stab wound there. And seat belt injury, you can see if the patient is a driver, the injury is likely to be the spleen, which is on the left-hand side, and if it's a passenger, it's liver likely to injure. Now, we always talk about A, B, C, D, E, how we breathe in circulation, but one of my bosses told me, hopefully I don't have many orthopedic surgeons here. For an orthopedic surgeon, it may mean bone capsule in drill and X-fix. I'm not sure whether we can talk about that. Now, the diagnostic aids, we always go for basic blood tests and a chest X-ray and spine X-ray as well. And nowadays, we have the CT scanner next to the emergency department. Once the patient arrives to the emergency department, after primary survey, the patient's being moved on to the CT scanner. They get CT head, neck, chest, abdomen, pelvis, and if you are suspected any bone injuries, they go back for a second CT. Now, this is a pelvic fracture. These are, be very cautious about the pelvic fractures. Patient can lose a lot of blood, sometimes 6-7 liters of blood, and you may not see that in the abdomen. It's all inside. So these patients, most of the time, they will go for an external fixation, and if the patient is stable, they will go to the radiology to have an angiography and with a view to embolize the bleeding vessel. Now, the splenic injury, you can see the blood on the opposite side. Again, nowadays, if the splenic injury is between 1 and 3 and no evidence of other injuries, we don't take the patient to theater, we try to manage them conservatively. On the other hand, splenic injuries 4 and 5, they will need surgery. But grade between 1 and 3, but the CT scan showing free gas, they will need surgery. Otherwise, you will miss the hollow viscous injuries there. And this is a liver injury. If we find liver injuries intraoperatively, we don't try to deal with it at the time. We mobilize the liver quickly, close the defect, and pack around it, and close the patient, send them to a tertiary center, or in my hospital, we send them to the radiology. And if he's actively bleeding, we have liver surgeons, we can get them with a problem. Now, what's wrong with this patient? Obviously, there is a rupture of the left hemidiaphragm, and stomach, half the stomach is in the chest as well for this patient. And it is common on the left hemidiaphragm because liver gives some protection to the right side of the hemidiaphragm. Now, again, I think I briefly touched about it. CT scan in trauma is good for solid organs, not for hollow viscous. But if that shows free gas, then yes, the patient will need a trauma laparotomy. The FAST scans stands for focused abdominal scanning in trauma or focused abdominal sonography in trauma. When we do that, if the patient is tachycardic but still stable but not suitable to go to a CT scan, then we can do an ultrasound scan, a FAST scan, specifically looking for fluid around the heart, around the liver, spleen, or in the pelvis. If we find those things, this patient will need to go to theater for a trauma laparotomy. But we don't do that if the patient is unstable. Now, this is a question, a fellowship exam in Australia 2012. So this patient was brought into the emergency department, 20-year-old, multiple stab injuries to the abdomen, and during primary survey, spontaneous breathing, saturation was normal. The blood pressure is 70 on 50. So this patient has suffered already a grade 3 and beyond hemorrhagic shock. What is the treatment for this patient? The only thing that can control this problem is stainless steel, which is the knife. So patient needs a laparotomy, this patient. And how do we do the trauma laparotomy? Every hospital has got a sort of a dedicated system. We can ring switch 9, most of the hospital 9 or 0, you can ask them to activate the trauma call. So what happens is they will send a paging messages to surgical registrar, surgeon, anesthetist, intensivist, saying Cat 1 trauma in emergency. And we also contact the nurse unit manager in theatre to get ready for the laparotomy. There will be 3 or 4 nurses will be ready to have this laparotomy, and 20 large packs, suckers, everything. Now, we also activate the massive transfusion protocol, because most of the hospitals, we don't keep the platelets. The hospital will contact the Red Cross, and they will get ready for platelets, but the hospital blood bank will get ready with O negative blood until they get the group and cross match. Now, when we do the operation, the sterility, we don't look for it. It's called sterility is luxury in trauma surgery. And then assistant will pour the betadine on the patient's abdomen, and you slip into the gown, glove, betadine, and you open the belly. We don't use diathermy there. 3 incision, you enter the abdominal cavity. And if you see a lot of blood, I just thought of mentioning this. A lot of the trauma books always mention this. When did this happen? When you're really tired and your anesthetist is trying to push fluids and inotropic agents, and these are the instances you will get a trauma patient coming to the emergency department. Now, when we do the laparotomy, if you see a lot of bloods, some will throw the packs into the belly. Now, we don't usually do that. We scoop out all the blood clots and 4-quadrant packing, and we wait. And this will let the anesthetist to catch up some time to get the temperature up, some fluid resuscitation if the patient needs blood, more blood. Then you can proceed with the operation. We try to take the packs where it's least likely to bleed. You can start from the pelvis or start from the liver. Then you go to the area where I think the most of the time the injury is going to be, depending on the patient's mechanism of trauma. Now, when the patient is having the surgery, you might look at the monitor. They'll say blood pressure is 120 on 70, good saturation, and you may think this patient may cope the operation. And you need to understand what happened to this patient preoperatively. The patient may have lost the entire volume of blood, and when he came to the hospital, the temperature may be under 36, 34. And if we say, yes, the patient is stable, at the moment I will proceed with the definitive surgery and try to anastomose the bowel, that is a bad movement, And you may have this sort of collection in your career if you try to do definitive surgery when the patient is not well. Now, the so-called stable patient had a physiological blow to his, before the operation was started even. And the systemic inflammatory response is going to hit the patient very quickly when the patient returns to the ward or to the intensive care unit. And oxygen will drop. Is all these abdominal compartments going to swell up? He will develop abdominal compartment syndrome. And we need to bail out. So we don't actually wait for all this to happen. You go there, you stabilize the patient, you packed it. If you think the patient is not suitable for a definitive surgery, you need to close the abdomen, send the patient to the intensive care with a view to come back, which is called the trauma laparotomy. Now, we are aware of the lethal triad. These are the biggest killers in surgery: hypothermia, coagulopathy, and acidosis. And we also call these 3 triads as the physiological envelope. A core temperature of 32, if the anesthetist is telling you the temperature is 32 now, you actually miss the boat. The patient will die invariably. Now, if you have a sound, I thought of writing this. If you understand the real physiology of trauma and also the lethal triad, you need to bail out. But if the anesthetist is telling you it's 33, temperature is pH is 6.9, you lost your judgment, the patient will die. Thank you.